Well, good evening, everyone. I'm Bobbi Daniels, Associate Vice President for Clinical Affairs here at the University of Minnesota. Welcome to the second session of the Mini Medical School, Health and Wellness During a Pandemic. We're very excited to have you here today, and we look forward to guiding you through our second topic in the series, the impact of the COVID-19 pandemic on other diseases. We've set this up as a moderated discussion with Q&A to follow. Please note that this session is being recorded and will be uploaded tomorrow on the Office of Academic Clinical Affairs YouTube channel. Today, we have the pleasure of hosting a panel that will be discussing the state of non-COVID infections and diseases and their immediate and potential long-term impact on health. If you have questions for the panelists or for me, please type them in the Q&A box and I will pose them to the panelists. And now, to introduce our panelists, I'll first bring in Dr. David Haynes. Dr. Haynes is an assistant professor with the Institute for Health Informatics at the university. Dr. Haynes is broadly trained health geographer who uses cutting-edge spatial analysis methods to advance our knowledge of health and cancer disparities. Dr. Haynes, can you talk about delays in cancer screening during the pandemic and the ultimate impact?
Yes, thank you so much. So thank you for the nice introduction. And I'm going to talk to you about some work that I've been doing with cancer and how COVID has impacted our ability to understand screening disparities and things like that. And I work with the Institute for Health Informatics at the University of Minnesota. Go ahead and go to the next slide. And the work that I will talk to you about today has no conflict. Next slide. So generally what we've seen is that across the nation, and this is also really relevant to what's happening here in Minnesota, is that screening rates have dropped substantially. So for the four major cancers, breast cancer, colorectal, lung, and prostate, we saw about 90% drop in rates of screening for the first 3 to 6 months during the pandemic. So this was a huge drop in terms of the number of people that we were expecting to come in to get their appointments every year. And we saw that essentially 1 out of 10 people was actually coming into the clinic to do that treatment or do that screening. And this is going to be hugely impactful for us in the next few years. We know that this is going to have lots of unintended consequences. So one of the things I want to kind of point you to is that this image here on the right, you might start seeing a little bit of language in different advertisements around cancer doesn't wait because we saw such huge drops in these screening rates. And so this is an image from the American Cancer Society, one of the advertisements. And there's been a lot of work recently on trying to increase and get people to go back and do these treatments because they're very, very important. But I also want to clarify that this screening rate was not just because people didn't show up. You know, a lot of the healthcare systems during the pandemic closed, and this was hugely impactful for everyone. And that closure has really changed a lot of things all across the country. All sorts of systems, schools, businesses were trying to figure out different ways of taking care of patients and how to be safe. And so we saw this essential shift, right, to closure, which really affected people immediately. And that's why we saw the first 3 to 6 months when you're thinking about March to June to September of 2020. That was when we saw the largest decline. And then we started to see these things, all the healthcare systems slowly open, add these additional services back. And we're starting to see our cancer screening rates go kind of back up and getting closer and closer towards normal. But we've also seen during that process that people generally felt that they were not safe and that the hospital was not where they wanted to be, which is really one of the places where you need to go to get screened. And so that this is still one of the ramifications that we're still currently kind of facing now, is that people still are feeling a little bit unsafe in going into the healthcare system. And so what we're trying to do is really encourage them to come back, go to the healthcare system as much as possible, because that's where they can get the best treatment that they'll need. And what we're really seeing now is that because of these delays in screening, we're starting to see at more advanced stages of cancer. So cancer is, we're happy to find cancer when it's smallest, when it's easiest to take care of. And what we're actually seeing now is that the cancers that we typically have seen are bigger, they're a little bit more aggressive, and this is going to cause us some issues later on. The treatments have to be more aggressive. It's going to be harder on people's bodies. And so we're trying to really get people back to doing the screening so that we can find the cancers when they get smaller and they're more manageable. So right now, that is the biggest thing that we're really trying to focus on, is how do we make sure that we get people back into the screening practice as much as possible. Go ahead and go to the next slide. And then we've also kind of had another issue that is probably a little bit different for many people that work in the space of cancer. I do a lot with data around breast cancer, but during the pandemic, with everything kind of happening so quickly, there was also, even cancer became affected in terms of misinformation. So in this case, one of the things that happened in terms of mammography, in February of 2021, when we were first starting to get our vaccinations out and people were starting to get more and people were getting screened, we started having problems, particularly in mammography, because women were getting vaccinated, they got their first shot, and then they felt that they had some level of protection, and so they went and they started taking care of their healthcare. And during that process, what they found is that sometimes these women were being called back because they thought they had detected a lump. So this was happening because the vaccination itself was causing your lymph nodes to swell, and they were picking this up and they were thinking that this was maybe a cancer. So this was an unintended consequence of one thing happening and not understanding the timing that needed to happen between a vaccination shot and a mammography screening. But we're essentially still trying to figure out all of these things, like anything that's related towards COVID, pandemic sort of things, has different ramifications for other parts of the healthcare system. And how do we kind of handle those things and effectively communicate those messages so that people still get screened, and you still need to be screened, but understanding that so if people don't get kind of very scary messages that they may have an abnormal screening and it's a false positive. So that's one of the huge things that we've been trying to do in terms of cancer, is really trying to focus really on communicating really well our messages to everyone about what's safe, what they need to do, because this is something that all places in the medical field are really fighting, is this disinformation. Go ahead and go to the next screen. And then lastly, I'll just kind of talk about the potential impact or challenge is with cancer. So as I said at the beginning, we've had lots of, 1 out of 10 people were coming and getting the screening when they should have. And we're starting to see more advanced cancers. If you have a more advanced cancer, that means it's going to be harder for us to treat you. But I try to think of this as a challenge for our healthcare system and how we can make this better. So one of the things that's really important is that cancer treatment, and particularly for breast mammography, is really effective, 99% effective, when you find it local and early. And the challenge is for us to really work with researchers like myself that are in health disparities and people that are part of the oncology care team that develop and use the treatments to make sure that these gaps don't get worse. So we've always had communities that have had these, what we call these gaps, that they're not surviving as long as other people. They don't get as much treatment. And what we really need to do is try to shorten those gaps. And if there's anything that the pandemic has kind of shown us, is that now we have the opportunity to really do those sorts of things. You have the opportunity to kind of change the healthcare system. And the best way to do this is to kind of reimagine everything that we need to do and really focus on how to make sure that those gaps, we can eliminate those gaps or shrink them as much as possible. So one of the things that I really focus on is connecting the community to the best care and trying to figure out new innovative ways of doing that. Next slide. And then the last thing here is that make sure you don't delay your treatment. If you are thinking about delaying your treatment, most healthcare systems, if not all, are at 100%. And there is, while there is a long backlog, just try to have some patience and grace for everyone that's a part of your team. And make sure you're advocating yourself. Especially if you're part of a minority population or one that's not typically, make sure that you're speaking up and making sure that your voice is heard so that you can really participate in your healthcare process. I think that's it.
Thank you, Dr. Haynes. And now we have Laura Palumbi. Dr. Palumbi is an associate professor at the University of Minnesota College of Pharmacy in Duluth. She's a member of the Opioid Advisory Task Force, a university system-wide opioid initiative working to advance knowledge of addiction and pain management through basic and translational research, clinical approaches, and policy. Dr. Palumbi, can you discuss the impact of the pandemic on opioid use disorder?
Yes, thank you. Thanks so much for the invitation to speak, and I really appreciate being able to share what I've learned on this topic. So before I begin, I just want to share my work focuses on rural and tribal communities. But of course, I can speak to trends that are going on across the state and the nation. And I also want to share that my work is community engaged. So what I'm sharing with you is what I've been hearing from the people that work most closely with individuals with substance use disorder and with opioid use disorder. So just to begin with, I think all of us probably know that that things have been really tough for people with substance use disorders since COVID began. We know that overdose rates are up in the last year. The year that ended May of 2020, overdose rates were the highest that they've ever been across the nation. So in that year that ended in May of 2020, we lost 93,000 people to overdose deaths. And those deaths, the majority are opioid involved. And I'm going to talk a little bit more about that. But those are all human beings who are valuable people, somebody's loved one, somebody's mom, dad, son, daughter. And so whenever I talk about statistics, I always want to talk about that because that's really important. Most of us have been touched by the opioid crisis. And so the opioid crisis was worsening for many, many years. But then when COVID came, we just saw this huge jump in overdose deaths. And that's one of the markers for how are people doing and how are we doing when it comes to opioid use disorder. And we saw that same trend in the United States. And another trend we've seen is that communities that are impacted by systemic racism are especially hard hit by the opioid crisis. And so in Minnesota, that would be our American Indian communities and our Black communities where we've seen those disparities. And we're actually the worst in the nation when it comes to disparities for American Indian people. And that's the area that I am fortunate to work in northeastern Minnesota. So why are we seeing these increased overdose rates? What's making it so much worse? Well, part of it is that all of us are doing worse because of the COVID pandemic. There's a lot of stress going on, a lot of anxiety. People who have struggled with depression are even more depressed. People who've not struggled with depression are depressed. There's a lack of consistency in our everyday life, drastic changes. And so all of the things that have made life hard for all of us are made worse for people at risk for a substance use disorder or those who already have a substance use disorder. So there's many people who have been in recovery for many, many years and doing great with their sobriety. And when COVID came and the pandemic hit, social isolation, that was a huge risk factor for people because they required those monthly meetings or weekly meetings, sometimes daily meetings, and that social connection helped keep them well. And once that couldn't happen, they lost those social supports. And so we've seen a lot of people who have been in long-term recovery who are struggling now that never were before. We're seeing people who maybe used just a little bit, maybe they were light substance users before COVID-19, but because of the reasons I mentioned, stress, anxiety, economic situation, their substance use increased. And then we have people who've never used substances that are starting to use them now. So maybe people who've never used drugs or alcohol who are experimenting. So all of those markers of how we're doing when it comes to opioid use and substance use have worsened since the pandemic. So that's what I hear from my partners in recovery and harm reduction. It's really challenging. I think one of the things that we're seeing is we know we've seen an increase in non-fatal overdoses. That's good. We'd rather have non-fatal overdoses versus overdoses that are fatal. One good thing is that we are slowly increasing access to harm reduction. That was one of the reasons that we saw so many increases in overdose early on in the pandemic is because we didn't have that same access to naloxone. Naloxone is the same thing as Narcan. It's a drug that reverses opioid overdose. And so that lack of access to naloxone contributed to our opioid overdose rates. We also had less access to treatment facilities. And this, of course, is exacerbated for people that are in rural communities and tribal communities, or those who have poor access to transportation. So again, we're seeing disparities in that area. Fewer treatment facilities. We already had a shortage of treatment facilities for opioid use disorder and substance use in our state. But then when you add in the complicating factors of COVID-19 and the pandemic, that's made that worse as well. So we have a lot of things going on. And beyond that, what kind of aligned with this as well is the introduction of more synthetic opioids. So synthetic opioids would be fentanyl, for example. That's the one that we probably hear of the most. And so fentanyl is a very, very strong, potent opioid. It is laced in many, many drugs, most drugs of abuse, and people don't even know they're getting it. So they might think that they're getting a pill, they think they're getting a pharmaceutical pill. But we found out, of course, that people are just manufacturing pharmaceutical pill lookalikes. You can buy pill presses online and make these fake pills, and most of them are laced with fentanyl. And so this is something that we're seeing a lot, and we have seen a lot over the past year, is this introduction of fentanyl into all of our drug sources. So people that aren't even opioid users. So you have people that typically use methamphetamine or cocaine, which are stimulants. They are at risk of an opioid overdose because there is fentanyl laced in their drug supply. So for all of these reasons, we are seeing these increased numbers of overdoses. And it's just been a really tough time. And I think I just really want to send a note of positivity out. Our folks that are working in the area of substance use right now are so busy and working so hard, and they are really doing a great job to adapt in whatever way they can. I would say trying to pull out a positive from the situation, we've had a lot of adaptations in the substance use world that have really been helpful for people. We have more telehealth services now that were never in place before, and that's been really key for people that can access treatment via telehealth. Of course, that's not everybody. In some of our rural areas, they don't have access to internet, so that's not an option. But for a lot of people, that's been good. I think a lot of our recovery circles that used to be in person have shifted to online meetings, Zoom meetings such as what we're in right now. And so that's been another positive that's really increased access for a lot of people who maybe struggled to get to that meeting in person, and now they're able to do it because of technology. We also have adapted prevention messages too. I think it's unfortunate that it would take a pandemic and this increase in overdoses to get the attention of lawmakers and funders, but that is one positive, is that we are seeing more funding for prevention and more recognition of the importance of prevention. So overall, there are some positives that have come from this. I think there's still a lot of work to be done, but people are working really hard at this. And I think that just even within the last month, I'm seeing a lot of really positives and a lot of renewed energy in the recovery community in particular, as they're starting to gain momentum and figure out how to do some of their services remotely. So I'm excited to answer any questions you have later on in this presentation.
Thank you, Dr. Palumbi. Now it's my pleasure to bring in Dr. Beth Thielen. Dr. Thielen is a physician scientist trained in adult and pediatric infectious diseases. She's developing a translational research program focused on human respiratory viral infections. She also studies the global burden of respiratory infections. Dr. Thielen, as we're heading into the flu season, can you talk about how COVID-19 and the flu have impacted one another?
Yes, thank you so much for the opportunity to come talk about this. And a little bit by way of introduction about myself. So the question that you asked, I really take three different lenses sort of to look at it. One is as an infectious disease physician who's been taking care of hospitalized adults and children with infections throughout the pandemic. Secondly, as a researcher who studies the cell biology and immunology of viruses. And third, the public health perspective through work in respiratory viral surveillance that I've done at the Minnesota Department of Health. And so the answer I'm going to give to you in the next few minutes will give you a flavor of sort of all these three perspectives. And so I want to begin with making sure that we all have a common language around terms. And so I want to begin with what is a respiratory virus? I think we sort of intuitively know of all the year, but just to go back to basics. So it's a very tiny microbe that can't be seen with the naked eye and requires the host cell to replicate itself. And specifically, respiratory viruses are those viruses that replicate primarily in the respiratory tract, and that can really be anywhere from the nose, throat, ears, sinuses, all the way down to the lower respiratory tract of the larger airways in the lungs. And we've known for decades that there are, in fact, many different types of viruses that can share those common symptoms of causing a respiratory tract infection. So it's not just SARS-CoV-2 or influenza or the flu, but other diseases as well. And these viruses overlap significantly in their symptoms, so that really the only way to tell which one you have is to get a test. And so to put it another way, many viruses can cause the same disease syndrome. And for the most part, having a test result doesn't change what your doctor will do, because we don't yet have the specific treatments we'd like to target each of these viruses individually. I think the second confusing thing is that sometimes the exact same virus can make one person really sick and another person cause no symptoms at all. Or to put it in another way, one virus can cause many different disease syndromes. And over the past 10 to 20 years, we've really seen a revolution in medicine, whereby researchers have developed new tests such that clinicians like myself are able to order a test that says exactly which virus or viruses a person is infected with. And right now, we're still fairly limited in our ability to give specific treatments or vaccines to prevent these or treat these specific viruses. But I think one of the things that's been really exciting about the innovations of the past 18 months is that it really has highlighted the possibility that exists to develop more specific treatments and vaccines now that we can identify the problem. And I promise I'm going to talk about the interaction between flu and COVID. But before I do, I also want to just give another introduction to a key virus that's probably equally as important as influenza, and that is RSV. And RSV has a very great significance in both the pediatricians and the parents among us tonight, in that it is one of the most common reasons for children to be hospitalized in a typical winter season. And many people will know of at least one infant in their friend or family group who developed a respiratory illness during the winter and got so congested that they couldn't stay hydrated at home and needed to come into the hospital for IV fluids and supplemental oxygen. And to put some numbers behind that, so every year in the United States, in a typical year, there's approximately 58,000 hospitalizations and 100 to 500 pediatric deaths in children under 5 years of age from RSV. And that's something like close to 1 in 50 infants under 6 months of age who'll get hospitalized every year. So it's really quite a substantial burden in a typical year. And adults are also pretty heavily affected by RSV, although we don't often call it that. So it's been estimated in some of these surveillance studies that something like 177,000 hospitals and 14,000 deaths affect those 65 years and older. So it really is, like influenza, quite a big health burden. And so what has the last 18 months meant for these other viruses, including both influenza and RSV? And I think people will remember the dire predictions that came out about the twindemic of influenza and COVID that were sort of predicted last winter. When in fact, what didn't actually pan out that way, anywhere near our worst predictions. And in fact, what we saw is that there was a really striking drop in other respiratory viruses beginning in the spring of 2020 that coincided with the closure of schools and workplaces and implementation of masking and social distancing. And it's really hard to convey how big a deal this was in the space of pediatric medicine. So to give some perspective, when I was an intern working in a local children's hospital, we might admit 10 or 15 children a night with RSV. And there's potential that pediatric interns that began their training last summer may not have ever admitted a child with bronchiolitis, which is essentially unheard of and so striking. To give some local numbers, so on a typical year in Minnesota, there's something like 2,500 to 6,500 people hospitalized with influenza every year. Last year, there was 35, and this year so far is 2. And similarly, we see that same trend in deaths. So somewhere between a few hundred deaths from influenza typically occur in Minnesota every year, and last year there were 7. So really striking drops in the typical respiratory viruses that we see circulating. Now, for thinking about how this happened, it's not too surprising based on what we know about how respiratory viruses are transmitted. We know that the majority of respiratory viruses are spread either through direct or indirect contact with an infected person's respiratory secretions. And I think we've all become experts to some extent in thinking about these infection prevention measures. And one thing I find useful to bring up with people is sort of some of these lessons learned years ago from other respiratory viruses. And in particular, as a pediatrician, there's a landmark study that I am very familiar with by an investigator, a researcher named Carolyn Hall. It was done in the early 1980s. And I think it's instructive just to think through how we learned the knowledge that we have. And so basically what they did is they had healthy volunteers spend time in proximity to children with RSV in one of 3 different exposure groups. So there were the cuddlers, and those were volunteers that were in direct contact with the ill children. There were the touchers who touched the objects that the ill children had touched and then touched their eyes and nose, but were not in direct contact with the child. And then finally, there were sitters who sat over 6 feet away and never came in direct contact. And I think they got a very striking result from this study, which is that there were high rates of infection with RSV in both the cuddlers and the touchers, but not in the sitters. And it's studies like these that really form the foundation of our today's infection prevention practices that tell us that interventions that block contact with secretions like eye protection and masks, particularly when they're paired with gown and gloves and good hand hygiene, can be very effective at preventing the spread of viruses. And that paired with behavioral interventions like widespread closures of schools and daycares really limited the spread of these other infections quite dramatically. Now, over the past year, we have seen viruses starting to come back, and it's been a bit at different rates depending on the virus. So during the Southern Hemisphere's summer in Australia saw a really dramatic rise in RSV cases during an atypical seasonal pattern. So typically it's a disease of winter, and they saw pretty high cases coming up in the summer, which is distinctly unusual. We have seen a similar trend here in Minnesota over this past summer with really high hospitalization rates for RSV among our young children. And interestingly, though, influenza numbers have not taken off in the way that RSV did. And I think, honestly, scientists don't really have a great explanation why. However, I think we have to do incomplete information, need to plan ahead for what's coming and kind of think through what's going to happen in the coming winter season. And given the surge in RSV and the return to more normal activities, I think many infectious disease specialists, such as myself, are worried that the flu case numbers won't remain low again this season. But exactly what will happen, I think we don't know. We have seen a few pieces of information that give us some food for thought. So we know that risk factors for severe disease are often shared amongst most respiratory viruses. And this includes being very young, very old, or having chronic medical conditions. And we know that pathogens can interact in a way that's unpredictable, and that there's examples in which one pathogen can either inhibit or promote another. So for example, the example of the former, my lab studies interferons, and these are signaling molecules described over 60 years ago that protect surrounding cells from a infection by a nearby virus-infected cell. So that's an example of one virus potentially causing signaling that inhibits another virus. We also see examples of pathogens like influenza increasing the risk of secondary bacterial pneumonias from other bacteria like pneumococcus or Staph aureus. And so I think we have examples of both mechanisms in literature, and I think it really remains to be seen how this will play out. And finally, I'd like to end with the concept that immunity from respiratory viruses is not an all or nothing phenomenon, and the immunity is often partial. And that we know that influenza vaccine protects against severe disease, but this protection wanes over time. And we know that our influenza-specific immune response gets a boost, both potentially through annual vaccination, but also by natural infection. And many of our immune systems took a little break from the usual exposures last season. So I think we are worried that the population may be more vulnerable as these viruses return. So to wrap up with take-home points, I'd like people to remember that behavioral interventions are highly effective, but not perfect at preventing the spread of respiratory viruses, and that the ways that different pathogens interact is complex and may be influenced by factors such as prior exposure history, co-infections, and other health conditions. I'd be happy to take further questions.
Thank you, Dr. Thielen, and thank you to the great presentations by all of the panelists. We're starting to get questions in, and I'd like to remind you that you can type in any questions that you have in the Q&A part of the Zoom window, and we'll distribute them as we have time. So the first question is for you, Dr. Haynes. And this is someone who says that they had the experience of needing to change their mammogram appointment due to the timing of the COVID-19 vaccination. And she wonders, what is the current message that is being used to avoid confusion amongst people who need the vaccination but still need the preventative care as well?
Yeah, I think right now what we are recommending is that when you're talking with to schedule your screening, that you wait at least 2 to 3 weeks as long as you haven't had any symptoms. And that's kind of where it gets a little complicated. Some people don't know how long their symptoms have lasted. So, but if you feel better after you've had your first vaccination shot or your second after 2 to 3 weeks, then you should feel comfortable having your mammogram then. But that's the recommendation right now.
Thank you, David. So Laura, here's a question for you, asking about fentanyl and how can it be stopped? And the writer questions whether the delivery from China pharmaceuticals must somehow come here. And could you comment on the extent to which the fentanyl is coming from China or other sources, and how we can be more vigilant at preventing?
Yeah. Yeah, I think it's a good question. So fentanyl, according to the DEA, the fentanyl supply in the United States is mostly coming from Mexico right now, from labs that are down in Mexico and then come up through the United States. I think fentanyl isn't extremely difficult to manufacture, so that's the tricky thing. I think it would be very difficult to stop. I know there's definitely some great efforts out there to stop it. And I think right now the most effective way to save people's lives is to continue educating youth and people who are using substances that we know that fentanyl is pretty much everywhere in our drug supply. They've documented fentanyl in our heroin, in this country, in cocaine and methamphetamine. So basically, if you are using a substance, a drug of abuse, you should pretty much assume that there's fentanyl in it. And if you are purchasing pills off the street, you should assume that fentanyl is in it. And that really there's the important place for education with naloxone. So naloxone is a generic name for Narcan, and that's the drug that reverses opioid overdose. So fentanyl is an opioid. It's a synthetic opioid that's very, very potent. And so if we can get more naloxone out in the community, that's probably our best approach right now to saving lives. Just increasing the accessibility and increasing the education. And fortunately, naloxone is available. We have standing orders with all of the bigger pharmacy chains in our state. So we have a standing order in place where anybody can get naloxone by going into one of those pharmacies and asking for it. It's also available through harm reduction agencies such as the Steve Rumler Hope Network in the Twin Cities and Rural AIDS Action Network in other areas of the state.
Thank you. Dr. Thielen, we have a question that I think is perfect for your expertise. Actually, there's a couple of questions and I'll try to combine them. There's someone who is asking about whether they should get a flu vaccine if they've been, well, I'll do them one at a time. Should I get a flu vaccine if I've been vaccinated against COVID?
So absolutely, yes. So that's an easy one. For the most part, there's a very few number of medical exceptions, but for the most part, almost anyone over 6 months of age can get a flu vaccine, and that should be possible to space separately from your COVID vaccines. However, I do really want to emphasize that COVID vaccines are sort of the number one priority. I've seen some unfortunate cases where people have missed out on an opportunity to get a COVID vaccine because of other sort of less critical vaccines. So I really want to highlight for people the importance. COVID vaccines are probably my number one priority right now, but it should be very possible to get an influenza vaccine as well before our season ramps up.
And here's the corollary to that question. There have been anecdotal reports of non-COVID vaccinations providing some protection against COVID-19 as well. Do you think this is only because people who get an annual flu vaccine are also those taking better COVID-19 precautions, or are there other mechanisms that are causing this?
Yeah, so it's a really interesting question. And I think potentially there's a room for both. So I think on a population level, it is often very hard to sort out behavioral traits that sort of flock together as the questioner asked. But there's a number of lines of evidence from Particularly, it tends to be around live vaccines, so things like BCG or oral polio vaccine, which are not routinely given in the United States, that these may have some sort of general immunostimulatory effects that may be cross-protective through mechanisms that haven't been totally sorted out. So I don't know that science is fully settled on that, and I think because we now have such great targeted vaccines specific for COVID, I think some of that research has sort of fallen by the wayside, but I think there is potential that both of those things may be at play.
Dr. Haynes, your presentation suggested that there's screening for lung cancer. They've never heard of this screening and didn't know there was one. Can you talk a little bit more about what the screening might be?
Yeah, sure. Yes, there is a screening for lung cancer. It's only maybe about 8 to 10 years old, but it's called low dose chromatography or something like that. It's basically a chest X-ray that you can do. There is some eligibility criteria, which means you have to be of a certain, typically you have to have smoked for so many years, but just recently, I think within the last year or so, they lowered that threshold. So I think it might be something like if you've had a smoking history of like you smoked a pack of cigarettes over 20 years, like you smoke a pack of cigarettes every day for over 20 years, then that's what would get you that threshold. But this is very helpful, and we'll look at your lungs to make sure that if you have something like any cancers in there, and help you kind of get the treatment that you need. So I would definitely recommend that. You can reach out to me and I can connect you to people here that do this.
Dr. Palumbi, one of the respondents is asking about what the university is doing to tackle the opioid epidemic. Could you comment a little bit on the broad research that's going on at the university?
Yeah, yeah, I don't even know where to start. I think, so I'm very fortunate to be part of we have an opioid task force at the university where it brings together a broad group of people that are in practice and in research to address opioids. And I am always impressed at those meetings at all of the work that's being done, from the basic scientists that are working on trying to find ways to create pain medications that are non-addictive, and just doing work on opioids in general and other ways to reach the brain, to turn off pain signals. Like the research there is amazing. And then we have people that do research and practice on accessing treatment for substance use, trying to figure out how do we make treatment more accessible? How do we improve our treatment outcomes? How do we reach the populations that are really suffering the most? You have people like me that are doing work with harm reduction across the state. So harm reduction is increasing access to naloxone, the life-saving drug to reverse opioid overdose, and other harm reduction be access to clean syringes. I also do work with the recovery community, and others do that as well. So really, research with the recovery community is focused on what are we doing well and what do we need to do better. So I would say there's just an incredible amount of research and really impacting all different areas of the opioid crisis. And really collectively, we're trying to talk to each other to make sure that we are, we don't want to duplicate any services, but we also want to find ways where we can learn from each other and collaborate better and really reach new populations. And so it's really neat. I think there's probably a web presence for that, so I can look that up. But I definitely encourage you, if you're also looking at, what is the university doing? We have where you can look up an expert. And so if you go to if you Google, look up an expert at the University of Minnesota, you'll find some of the people that have signed up to be listed as experts in all the different areas within opioids that they are working.
Okay, thank you. Dr. Thielen, do respiratory viruses compete, work together, or show any signs of interacting with each other?
Yeah, so another really interesting question. And so I think from some of the references that I made to the interferon system, I think we do have pretty good mechanistic understanding that sometimes viruses can inhibit through this induction of a common antiviral host defense mechanism, potentially can sort of crowd out other respiratory viruses. That being said, how this plays out in people is far less clear. So, as a pediatrician, I take care of a lot of children who test positive for 2, 3, sometimes 4 respiratory viruses. So clearly they're having multiple viruses coming in, and we don't really understand the mechanisms whereby that happens, where kids can get these multiple infections. And I think something that my lab we're really interested in studying is this interaction between these viruses.
Okay, thank you. Dr. Haynes, how do delays in cancer screening affect underrepresented minorities?
So the delays in cancer screening, so African-American women, I'll just talk specifically about breast cancer, which I know the most about, but African-American women typically have a gene which can help them have a more aggressive form of cancer. And what happens in that case is that it's harder to treat and they have a lower survivorship. If there's a delay, the recommended screening is that you get screened at about the age of 40, but African-American women sometimes have cancer when they're about 35 or younger. And you can imagine that if you waited 5 years to get a screening, that is going to make the cancer more aggressive. It's going to be harder to treat. So anything that, particularly for minority populations, particularly for African-American women and breast cancer, any sort of delay can really affect the amount of your life that you'll have. So you want to make sure that you get that screen as quickly as possible.
Okay, thank you. Dr. Thielen, there's someone in the audience who was diagnosed with multiple myeloma and then subsequently with COVID and had a very protracted period of time in the hospital, 4 months, requiring a tracheotomy. And they are recovering from that prolonged hospitalization. And now the multiple myeloma is in remission. And they're asking, have other patients with COVID experienced anything like this?
Well, I'm very sorry to hear about that story, and it makes me sad to hear of people struggling, and particularly knowing that our immunocompromised patients have been particularly hit hard by COVID and are less likely to respond and be protected by vaccination. So, unfortunately, yes, I would say that is a fairly common story as an infectious disease physician, that the folks that we are seeing now in the hospital, particularly most severely ill, are folks whose immune systems aren't able to sort of operate at maximal capacity to protect them. And then, so that's a good chunk. We are also still seeing a lot of folks younger folks coming into the hospital and having very severe courses right now. And those folks are almost exclusively unvaccinated. So it's sort of a mixed bag at this point of people who are unable to respond to the vaccines due to their medical illness, but also people who have not been able to be vaccinated yet.
So here's another question for you, Dr. Thielen. I've seen opportunities online for seniors to participate in RSV studies for payment. Should seniors volunteer for these studies, and what are the risks? And maybe the corollary question is, are non-children affected by RSV?
Thanks for that great question. And I don't want to comment specifically on any particular study, but I can say in general, it is very important. The work of medical research is critical that we have all people who are affected by the disease to be represented in our studies, because we really want to make sure that when we make recommendations that it's tailored to individuals' particular circumstances. So yes, I think it is critical that we have people representing all different ages and sort of backgrounds represented in clinical studies. And I think, I say this as wearing both my adult and pediatric infectious disease hat. I think the burden of RSV in adults is really dramatically undercounted. So there's been a few good studies that have looked at this, and when we look, we find it. I think it suffers from a little bit of a perception problem that RSV is perceived to be a disease of young children. But I think for any of us who know, who have grandparents taking care of children, I think there's a lot of mixing of all ages in the households, and it certainly, we see the older extreme age ranges being affected, or similarly to other respiratory viruses as we do for RSV. So I think it's absolutely a gap in our knowledge, and I think has a real potential benefit both to the the questioner to have that access to that tool, but to our society in general to have access to tools to prevent this really, really substantial burden of RSV disease.
So I have another one for you. There have been a lot of cases of people who are still suffering from the after effects of a COVID infection, such as fatigue. Do you think these problems will be lifelong, or is any type of recovery possible?
Yeah, so it's a good question, and I think we don't really. It's such a new disease. I don't have any great answers to tell anyone. I wish I had a crystal ball, but I don't. What I can say, based on what we've learned from other post-infectious complications of other infectious diseases, is the symptoms can be lingering, but they tend to respond to a comprehensive program of lifestyle sort of interventions and therapies. So that's something, my partners in pediatrics and as are my colleagues in adult medicine really engaged in sort of getting people who are suffering from these long COVID effects into comprehensive clinical care focused on a mix of pulmonary rehab and physical rehab and treating other kind of focal symptoms and getting people on the mend from these. So I think very much it is possible, and I think there are people very interested in helping care for patients suffering from these symptoms to help them get restored to function as much as possible.
So we have two questions related to COVID vaccinations, and that was actually the focus of our meeting last week. And I know that none of you three panelists are necessarily the experts in this particular area, but I'll certainly put the questions out and see if you have a comment. The first is the COVID booster necessary for those who've had COVID infection and received both doses of the COVID vaccine?
Well, so I can sort of channel who is probably a local commentator, Dr. Michael Osterholm on this, because I've heard him speak about this issue recently, and I think we share thoughts, which is I don't know that there's great data that says it's absolutely necessary, but I think what we have seen is that, and what I would counsel people is that it's probably the risk, there does not seem to be a risk of adverse effects. And I think certainly we're seeing a fair number of breakthrough cases, both with natural immunity from prior infection and from vaccination. And so I think we are still encouraging people as much as possible to get the vaccine on top of, don't let the prior history of prior infection be a block to getting vaccinated as well. That's very much clearly the message. Whether it is strictly necessary, I don't know that we entirely have the data there to say that it's absolutely necessary, but I would encourage most of my patients to go ahead and get the vaccine regardless of prior infection.
So Dr. Osterholm was one of the panelists last week, and you did indeed channel him very well. So Dr. Palumbi, what's the reason for fentanyl being mixed in with other street drugs?
That's a good question. And it's a question that comes up a lot because fentanyl is deadly. So the question, is puzzling, I think. Why would drug dealers want to introduce a deadly drug into their drug supply when that's how they make their livelihood? And when I've asked this before, the answer I've gotten is that when people are using substances, and of course this isn't going to be for everybody, but there's an additional high that you get if you have a drug with fentanyl in it. It's a little more potent. And so sometimes people seek that high, and it's almost like a pride thing, like, oh, well, because that's the same reason we've found, like, sometimes when somebody experiences an overdose, we wonder, why do people all of a sudden start buying more from that dealer that sold that drug that gave somebody the overdose? And there's that thought that person wasn't smart when they were using, but I'm smarter than them. So I'll be able to handle that and still get a better high without overdosing. So that is part of it. I still don't have my head wrapped around it, but that is what I've heard from people in harm reduction. But the other piece is that I'm a little puzzled when it comes to drugs such as meth and heroin. Obviously there's an additional sort of high when it comes to, sometimes people combine an upper and a downer, and it's called speedball. So that's when you mix, say, heroin with cocaine or heroin with methamphetamine. So there is going to be some sort of speedball effect when you add fentanyl to cocaine or methamphetamine, which are both stimulants. But I think it's tricky because a lot of people who are taking those stimulants don't even know they're getting fentanyl. So they're not purchasing it that way on purpose. And they are very surprised, and as are the people that they are using drugs with when they experience an overdose. So I think some of it we know and some of it we just don't know.
Okay, thank you. Dr. Thielen, could getting COVID-19 as a child, or like someone in development, possibly have worse outcomes long-term than an adult or someone who is no longer in development?
Okay, so the question is about, looks like it's about natural COVID-19 disease and not vaccination. Okay, so I think generally speaking, children have been more mildly affected by COVID than adults in general. That being said, we certainly have seen plenty of severe disease in children. I've personally cared for children who are severely ill in the ICU with COVID, so it does happen. It's just at a lower percentage of infected children go on to develop severe diseases compared to older folks. And we certainly see long COVID happening in children as well. So I would say, in general, on average, if you were to take a child versus an adult, the chances of having sequelae is lower for a child, but it's certainly still clinically significant.
So here's another related question, although at an earlier time in the child's life. Do you expect any long-term effects for children or babies of pregnant mothers from the COVID vaccine?
So I think the data that we have has been overwhelmingly clear on this point that the COVID vaccine is safe and effective in both pregnant people and in breastfeeding people. I think anecdotally, I will say some of the earliest people, that were coming out publicly about getting COVID vaccine were other pregnant healthcare workers. And so I think what I've seen in general, the security, of desire to get that and avoid the negative pregnancy effects of natural COVID have really won over healthcare workers. And I think we've subsequently seen some very large scale studies come out and be published looking at pregnant people at all trimesters of pregnancy, showing that the vaccine does really have an excellent safety profile throughout pregnancy. And I will also add that I, personally, I'm aware of multiple cases of adverse pregnancy effects, both placental injuries and effects in neonates, severe illness in neonates who acquired COVID. Certainly not the usual, but it definitely does happen. And so I think on balance, the data really support the safety of vaccines over the risk of natural infection.
Okay, thank you. Dr. Haynes, thinking broadly about the work you've done on cancer prevention, do you have any insights into how other diseases might be impacted by the pandemic in terms of preventative treatments?
Well, let me just kind of focus maybe on just some of the chronic diseases. I think that we're starting to see, lots of people have delayed care overall. That's just kind of across the board, like everyone's kind of talked about. And so we're starting to see that there's kind of this backlog of conditions that people aren't going into the healthcare system for, that they need to go into for. So I think that we're trying to figure out how to find the populations that have these groups and need to bring them into the healthcare system as quickly as possible to get their care up to date. And so I think that's the goal right now, is to try and reach those populations quickly and effectively so that they can get their care.
And here's another question for you. Have there been new or extended efforts to encourage people to get cancer screening during the pandemic?
Yeah, I actually ran a small pilot during the pandemic, unfortunately, I guess, around breast cancer screening, where we recruited women to get access to care. And we were doing stuff with mobile mammography, where a truck was essentially going to different places where you could kind of go to a community center and get screened. And those are some of like the innovative ideas that we need to do to kind of bring healthcare back out to people, to get them re-engaged where they feel safe. So there are definitely opportunities to do that. For cancer very broadly, there's lots of effort to try and reach these marginalized populations right now to try and get them screened. So that's kind of our goal.
Great, thank you. Dr. Palumbi, people with addictions have often been forced into virtual meetings rather than in-person support meetings. Have the virtual meetings really been as useful as in-person meetings?
I think that's hard for me to say. I'm not a person recovery, so it would be better coming from a person recovery, but I can tell you that I feel from my conversations with the recovery community, they are so busy now compared to where they were a few years ago. And that's due to a lot of different changes. It wasn't just COVID. I think more recognition for the role of peer recovery, coaches and the peer recovery community, more funding, just allows them more people. So I think that fortunately in our state, we've seen a huge increase in the number of people that are trained in peer recovery. And because of that, we're seeing more events. And I think it's tricky. We do know that one of the things that helps people in recovery is those social connections. And so it's hard to really measure, how many lives are saved because of the increased investment we've put into recovery, but definitely there are some. And recovery coaches can help people at all different stages. When people are still using, when they are in recovery, they're just versatile, wonderful people. And so I think things have changed, but it doesn't mean that they're less effective.
Okay, thank you. I think we have time for one last question. So delayed screening or treatment because of fear of COVID, to what extent does loss of a job and therefore insurance play into the delays related to screening? Or is there a protective mechanism in place for those situations? Do any of the panelists have a thought on that?
This is for cancer screening?
Sure, yes.
So yes, there are some programs in place. The Minnesota Department of Health does have a cancer screening program for breast cancer, cervical, and colorectal, where you don't have to be insured to get screened. There are, depending on where your financial situation is at, it's definitely a difficult thing to navigate, but there are resources available for you to get access to get screened, because screening is something that's kind of a part of your insurance plan, and even like the Minnesota Care and things like that. So in that case, yes, there are those sorts of programs, but it is definitely a difficult situation that you need to look through.
Well, I think we've reached the end of the question and answer period. I'd like to thank the panelists for their time and sharing their insights into the state of non-COVID infections and diseases during the pandemic. I would also like to thank all of you, the participants in Mini Medical School, for joining us today. We'll see you again next week at the third Mini Medical School session on health and wellness during a pandemic, which will be at the same time next Monday. We have an amazing group of experts that will discuss the pandemic as a psychological phenomenon. Good night.